here. Today my topic is about the dematiaceous fungal infection in solid organ transplantation. This is really, it's a very rarely seen, but recently there is a noticeable increasing in this solid organ transplantation patient. So I just give you an overview of this field. So Dematiaceous fungi, so-called black fungi, as you already know, it's a large and heterogeneous group of filamentous mold, which distributed very widely in the nature. You may see them everywhere, but the characteristic of this group fungi are dark-colored colony and dark cell walls. Why? Because they produce the brown melanin or melanin-like pigment in the cell wall of the hyphae or conidia or both. So like the picture show, it's dark, very dark, and even black. So the pathogenic dematiaceous fungi mostly belong to the Ascomycota and belong to the following four orders, like the Chattotheriales, which including Cladophiloflora, Exophiella, and etc., and the Dociodyales, mostly including Aurea basidium, and Solidiales are Phaeoacremonium and the Chitomium. And Pleosporium, including Alternaria, which quite often seen in the transplantation patient, and Bipolaris cavalaria and Exohelium. The clinical disease caused by dematiaceous fungi are including most commonly the cutaneous and subcutaneous infection like chromoblastomycosis, which recently was pointed as by the WHO as the neglected tropical disease. And the field hyphomycosis may including from the superficial to the invasive clinical type, and others including the eumycotic mycetoma and some superficial fungal infection like the onychomycosis tinea nigra, which often seen in South Asia area, and black piedra and keratitis. So let's focus on the field hyphomycosis. And quite recently, Professor Weida Liu's group reported, and there is a summary from the 1987 to 2021. There is 184 cases of proven field hyphomycosis reported in Chinese and English literature in China. So the epidemiology, species of the fungi and MIC and clinical features, treatments, and prognosis were analyzed. And from this review, we can see the most common risk factors were traumas, which take about 37, and diabetes and corticosteroid use, which separately 11%. And like this morning, Professor Chakrabarty mentioned the Ca9 deficiency in the dematiaceous fungal infection in China. It seems one of the major cause because it's influenced the innate immunity of the patient, which took about 77%. And also we can see the kidney transplantations took 3%. These are the frequently risk factors in patients with disseminated central nervous system and deep local and pulmonary infections. Well, the mortality of the cerebral, disseminated, and pulmonary field hyphomycosis are 55, 36, and 25% separately. But the overall misdiagnosis rate of field hyphomycosis was nearly 74%, and the moderate to severe rashes are accounted for 82 of subcutaneous field hyphomycosis. Here we can see the number of the cases seems has increasing in recent 10 years. And these are the demographics and risk factors of failed hypomycosis. We can see totally among the 174 cases, we have the 8 cases with the organ transplantation. So we can see the most common is kidney and liver and heart and lung. So kidney was the most common. Well, the most common clinical types are subcutaneous. We have 4 cases. Others are the pulmonary. We have 2, and 1 of the disseminated. No central nervous system infection in Chinese patient. The carni and some other risk factors. So the solid organ transplantation is an established and practical definitive treatment option for patients with end organ dysfunction. So the evaluation of solid organ transplantation has seen the field progress rapidly and over the past few decades with the incorporation of the variety of solid organs like liver, kidney, pancreas, heart, and lung into the donor pool. So the SOT recipients are particularly at the risk of invasive infections due to the prolonged immunosuppression. So in the organ transplantation patient, the major clinical type of the failed hypomycosis are cutaneous, which so-called soft skin tissue infection, and disseminated, and pulmonary and central nervous system. The pathogens are a variety of pathogens, which almost more than 20 genera. So there is a guideline of the American Society of Transplantation, IDCOP, which showing the emerging fungal infection in SOT recipients. These guidelines showing some important guideline of how to manage of this group of the patient. And there is a large review from nearly 50 years of the Dematiaceous fungal infections in SOT. So this is the systemic review, and with the Bayesian meta-analysis by Dr. Radcliffe and his colleagues. Also, there is a case series and literature review by Dr. David Lopoto, an Italy group, quite recently with the failed hypomycosis report in SOT recipients, and it's a case series and a narrative review of the literature. So I will summarize these 3 references based on their reported cases, including the epidemiology and the risk factors and infection types and microbiology, susceptibility results, and treatment outcome. So according to the big review, the total of 149 reports on 201 cases of Dematiaceous fungal infection in SOT published between past 50 years, and there are 94 cases between quite recent 10 years. So it means there are an obviously increasing of the reported cases. All the transplant patients are at risk, and the infection can occur at all times along the post-transplant continuum. Here we can see the mean age of the patient, and the male seems the most majority, which took about 72, and transplant organ first is kidney, and followed by the lung, heart, liver, and some pancreas or combinations. The time between the transplant and the infection is about 31 months with a big variation. And if we look at the epidemiology and the risk factors, and the development of infection requires susceptible host comes in contact with the causative fungi, which are very popular, widely distributed in the nature, and that the fungus survives and thrives within the patient. The exposure to emerging fungi is generally due to direct skin contact from the environment sources. So the reported exposure sources including the gardening and the trauma. The infection types, skin and soft tissue infection, SSTI, seems the most common infection type, which took about 73%, and followed by central nervous system and disseminated, which 11% separately. So, and the pulmonary infection took 5%. So this is 4 major clinical types. Here you can see the picture, SSTI, CNS infection, and pulmonary infection. If we look at the microbiology and susceptibility, totally 25 genera were identified among the 186 cases with fungal isolates identified at the genus and species level. Here we can see the most commonly isolated pathogen were Alternaria species, and followed by Exophiella, Varroconis, Cladophiloflora, Phaeoacrimonium, and others. And here are some pictures showing Alternaria alternata and Exophiella cenobiota and Varroconis galapawa. So the MIC derived from the BMD method or sensi titer EASL1 were available from only 37 fungal isolates. So here are the, I'm not sure you can see clearly or not. Anyway, we can see generally speaking, most of the isolates were susceptible to the triazoles, but and amphotericin B, but not fluconazole, not the fluocytosine, and some of them are susceptible to the echinocadins. Here are the continue of the MICs. Okay, we can go deeply into the genera and species. And some people tested the isolates of Bipolaris spicifera, and we can see they are seems to susceptible to most of the antifungal agents, except of the fluocytosine and the fluconazole. And how about the case of Cladophiloflora bantiana? So we can see most of the isolates were susceptible to amphotericin B, itraconazole, voriconazole, posaconazole, isoconazole, but not anidulafengine, but not susceptible to fluconazole and caspofungin. Here is Acroconis mucei, which are relatively resistant to most of the antifungal agents. We can see the MIC, it seems only lower in the case of terbinafine and some of the mechanocadins. So the Varroconis galapawa seems are sensitive to amphotericin B and the itraconazole and posaconazole and anidulafengine, but not to the other antifungal agents. So this is the Exophiella dermatitis. It seems too sensitive to most of the antifungal agents available now. So if we look at the therapy and the outcome, the median duration of therapy was pretty long, which lasts about 3 months, ranging from 0.1 to 40 months for the 120 cases reported duration, reflecting the heterogeneity of the presentation and clinical course across the reports. And we can see the most common used antifungal agents are itraconazole, voriconazole, posaconazole, and amphotericin B. And these are the therapy and the outcome. The patient receiving the procedural intervention for infection is about 67%. So that means the procedure, the surgical therapy seems most important schedule too. And SSTI, it's 71% with the incision and dredging, local excision, and debridement. The pulmonary infection, 18% receiving the leptomesis, and the central nervous system, nearly 60% received the surgical drained and resected. So even the therapy received, still the death rate of the patient with the dematiaceous fungal infection, nearly 7%. So if we look at the death case, mostly with the disseminated infection and central nervous system infection and pulmonary infection, the SSTI are pretty, and the pulmonary infection are relatively low. Here I would like to show you 3 cases reported. First one by Taiwan doctor is a renal transplantation patient with a cutaneous phaeohyphomycosis due to the alternarious basis. So the clinical improved was achieved by combination of amphotericin B, white packing, and systemic antifungal therapy with oral voriconazole. And second case was reported in China. It's a renal transplant received with subcutaneous phaeohyphomycosis by Hong Kong Mrs. Snow-Kinrom. The condition improved significantly by systemic antifungal therapy with oral voriconazole, completely cured, you can see. The third case were not so lucky. It's a very rare infection caused by Lasidiopodea cerebromia pneumonia in a patient who died 14 days after the cardiac liver transplantation. It's a dematiaceous mode recovered and identified by the Dr. Patrick Wu, which published in Journal of Clinical Microbiology. So in the case of the phaeohyphomycosis, I would like to summarize the dematiaceous fungi are important cause of infection in solid organ received. The early diagnosis and the therapy are critical in prevention the dissemination of the disease. The diagnosis relies on the clinical suspension paired with mycological investigation. And treatment of these infections continues to be a challenge. So that's all of my summary of this field. I would like to take the questions. Thank you so much for your attention.